And I would like to thank Dr. Julio Moran for inviting me back to to INCOR and to the wonderful city of Lima, where I think I've now been visiting for 3 years. It's a pleasure to, again, to be able to work and talk with Dr. Arboleda, Dr. Morales, and hear of all the good work that you are doing here. Dr. Arboleda told me this morning that he remembered my first talk in Lima 3 years ago. And thank you. During that talk, I spoke about the importance of detecting all babies with critical congenital heart defects using pulse oximetry. And, you know, this technology is now spreading around the world, simple technology. In the United States, it was shown last year in a published that it's decreased mortality in the United States by 30% in babies with critical congenital heart disease. So finding the babies, getting them into treatment does make a difference. And I think given the good work that you're doing here at INCOR, I now understand that perhaps it may be moving towards a requirement in Peru for babies to be screened, which hopefully will make the care here even better than it already is. So I was very excited to hear that. Today, I'm going to talk on the other side of it, not finding the heart disease, but what happens once you find it. And we're going to talk about surgery for congenital heart disease and how we've seen dramatic improvement comes. We'll start the talk by discussing some differences between early and late outcomes. We'll talk a little bit about why, what advances have made for improvements in surgery in the current era, and I'll identify some challenges to address in future congenital heart disease care, and talk about something very important that will be coming out in a publication soon that we have on the disparities in access to care around the world for congenital heart disease. Well, a surgical talk on improvements should always start with where we had our roots. And the roots of surgery came with Dr. Gross, who in 1938 ligated a patent ductus arteriosus at Boston Children's Hospital. What people may not know is he was fired for that because at that time it was not considered safe to operate on children or actually even to operate on the heart. The only operations that really had been done, and even those were considered very risky, were in trauma. And so from when Dr. Gross's started doing work in an animal lab, his chief of surgery said, yes, but don't ever do it on a child. He waited for the head of surgery, I don't recommend this here, but he waited for the head of surgery to leave town. And when the head of surgery left town, he operated on the first child with a patent ductus. It was 6 years until the second condition was able to be operated on. And that was, it's a little bit of an argument as to whether it was Dr. Crawford. And I think Dr. Crawford probably does get the acknowledgement. He did the second operation, coarctation, but Dr. Gross beat him to the publication. Dr. Gross did a case in Boston. So he published it first, but I think in Sweden was the actual second condition that was operated on. It was another 8 years before someone figured out how to enter the heart and operate and close an atrial septal defect. In 1952, using deep hypothermia, Dr. John Lewis opened the atrium of an individual and closed the atrial septal defect in what was at that time simply circulatory arrest. Dr. Gross decided that he might be able to do it on a beating heart and used a well technique. He simply sewed, I call it like a coffee filter, to the heart and blindly would reach in and bring the two two walls of the atrium together, sewing blindly to bring those together. You can imagine how dangerous this might be, because I do know even when surgeons occasionally have looked into the heart, they've brought the valve of the inferior vena cava over to the septum secundum, which directs all of the inferior vena cava blood to the left atrium. So doing it blindly, you can imagine what might have happened with some of those cases. Dr. Lillehei in '54 did cross-circulation between parents and children to correct intracardiac disease. And in that same year, the first bypass machines started to become into use. So as you can imagine, these early years were really exciting. Operations were rare under age 2. The optimal age for surgery during the early era was said to be 10 years old. So you can figure that if the optimal age was 10, many conditions just died before any surgical correction. Bypass complications were very common. There was not the ability of using circulatory arrest. So there was a lot of early mortality. And not only early mortality, there was also late mortality. And the late mortality was brought to our attention in these two studies in 2001 in the Nordic area in Finland, and in 1991 in this study that was in the United States, where basically they showed that late in the 20-year results, many children were still dying late after their surgery, and that the first operation oftentimes was followed by a second or a third operation. So this brought about the whole idea that looking at early results are nice, but the real thing with a child is looking at the late results. Now, the 1980s I consider the kind of transition year. In the 1980s, that's when things got exciting. And I actually started my training in the 1980s. Prostaglandins became available so that babies with ductal-dependent heart disease could be kept alive and they didn't have to go for operations emergently. Non-invasive imaging came to bear. Two-dimensional echo became very common. Team-based care, doctors, nurses, intensivists, all working together with a common goal. Interventional catheterization started augmenting the surgical procedures. Circulatory arrest came into play. Early primary correction, and the development of cardiac ICUs. All resulted in an exciting time and the promise of improved outcomes. So now, in the year 2019, almost 2020, we've really come to expect excellent early results. This is data from the STS database and the 120 or so US centers. And you can see that on this slide here shows that mortality is around just a little over 3% for all children. That's this median line here is the 3% line. We have some hospitals that are doing better than 3%. We have some hospitals that aren't doing as good as 3%. Some of that depending upon case mix and volumes and such. But that is still 30-day mortality, and it does not tell us the whole story. What happens late? This was a study that was done by a graduate student, Dr. Razadati at the University of Helsinki, and I was able to go and be his opponent in his PhD presentation. And what he did is, in Finland, they have a database that tracks back to 1953. And they have between 1953 and 2009, they had almost 11,000 patients under the age of 15 that underwent surgery. And they tracked them and matched their operations to the the National Death Registry in Helsinki. And what you can see is kind of a nice story of congenital heart disease surgery. So in 1953, surgery was not very common, but it grew up into the 80s and kept growing up until the end of the 1990s, almost 2000. In 2000, things started to plateau and actually drop, and that was a result of interventional catheterization, ASD closures, PDA closures, valvuloplasty procedures. The number of surgeries each year dropped during that time. You can also see the impact on the population, the birth rate. The birth rate was quite high in the 1950s and basically was dropping during most of that time when the rate of operations was increasing. Now it's been fairly steady birth rate. And this is the important, probably one of the key slides in my talk, and it shows the, basically they have a control group. Within the control group are based upon survival in Finland, 86% survival at 60 years, and this is it is the solid black line right here. That is the general population. And then, I'm sorry, the population is here, this dashed line. And then for all of congenital heart disease, which is this line, you can see that for congenital heart disease, there is a gap between the congenital heart disease and the control group. The early loss is around operative mortality, but there's also a late loss of life after the congenital heart disease is repaired. And then you can see for all the various conditions, from the simple conditions like ASD and PDA, where they are doing much better, much closer to the general population, and the single ventricle conditions, which have a larger gap from the control group. If we look at each individual condition, this is patent ductus arteriosus. There's a couple things that are interesting about patent ductus arteriosus. Again, looking at the early years, so this would be the 1950s and 1960s. Again, this is children getting operations late, not getting their procedures done under the age of 1. And these are children that are at risk for pulmonary hypertension late. And so you see this late fall off in survival in patent ductus arteriosus. If we look in the current era, in the 2000 to 2009, we see that there's less of that fall off in the patent ductus arteriosus because of the earlier interventions. And the same can be said for atrial septal defect. Look at the early era in the 1960s, significant gap from the control group of 86% survival. And this is, again, the result of operating late on atrial septal defect. Children that were operated over the age of 10 are at greater risk, and certainly those over the age of 20, for late complications with pulmonary hypertension, atrial fibrillation, and right heart failure. The cath closures in the 2000s certainly impacted the numbers of patients getting ASD surgery, but the mortality in the 2000s has dropped. The early mortality has dropped, and the late survival, right now 10-year survival in the late era is 100%. So by operating earlier, one can have better late results. Coarctation of the aorta is the one that really bothered me. And I remember hearing a talk maybe about 20 years ago, and it was from an adult congenital heart disease specialist, and it was somewhat chastising pediatric cardiologist. And of course, being a pediatric cardiologist, I really didn't take kindly to being chastised. But what they showed was this tremendous gap. I thought of coarctation as being something that was easily corrected and had great late results. But if you look at coarctation, this is the early era, 1950s, a lot of early deaths and a lot of late deaths. Remember, they're not getting the coarctation fixed and probably until their teenage years during that era. And so these were patients that were still at risk for stroke, hypertension complications, and heart failure, endocarditis, and such in their late recovery period. And even as we went into the 70s, the age of repair came down to being around age 5, and then in the 80s, it came down to age 2. We're seeing an improvement in survival, but there are still late deaths even after coarctation of the aorta. And that, again, is most likely as a result of residual arch obstruction or some of the other disease that can go along with coarctation, aortic valve stenosis, some of the children that also have ventricular septal defects. Ventricular septal defect, you can see clearly the impact of the early era versus the current era. In the early era, a lot of early deaths in the operating room and recovery time period, a lot of late morbidity, mortality related to pulmonary hypertension and heart failure. And you can see that now the longer-term survival, there's much less drop-off in survival and closer to the control group as we've operated on sooner for ventricular septal defect. And tetralogy of flow, all these will follow similar curves. I don't, for time's sake, I won't go into all the details of, but you can see the common theme that the early era had the higher early mortality and the more late mortality compared with the current era. The other thing that comes out of tetralogy of flow is the impact of primary correction versus staged correction. Primary correction does much better than staged correction. So in other words, the approach of, having a Blalock-Taussig shunt on every baby with tetralogy if they're under 6 months is associated with a higher mortality over the late course for those children. Transposition, same story. And of course, the great thing with transposition was the switch from the atrial type switch procedure to the arterial switch procedure. And when that was done, the late mortality significantly improved. Hypoplastic left heart syndrome, much more early deaths and late deaths. Less data in Finland because they were slow to adopt the policy of taking infants to surgery for hypoplastic left heart syndrome. And then single ventricle follows the same pattern. Now, one of the things that this manuscript does, and it's published in the Journal American College of Cardiology, is they were able to look at the causes of deaths, the late causes of deaths. And as the conditions increased in their complexity, the late morbidity and mortality was linked to the residual heart disease. And you can see that for single ventricle patients, over 90% of the late mortality is residual disease associated with the single ventricle condition. And this is just a bar graph that shows that. This is it's the cause of death, and congenital heart disease related cause of death is in blue. non-congenital heart disease related late deaths is in the orangish color. And as you see, here we go from patent ductus, ASD, coarc, VSD, the more simple conditions, to tetralogy, transposition, hypoplastic left heart, and single ventricle. And you can see as complexity increases, so does the percentage of late morbidity related to the congenital heart disease. And what this speaks to is the idea that as pediatric cardiologists and as adult congenital heart disease specialists, we need to have a plan for the late follow-up of patients. In other words, just repairing them and sending them on their way is not a good idea. They need to have their repair and then enter into an organized surveillance plan that monitors them through their childhood years and into their adult years. How about non-congenital heart disease-related deaths? This is where I think the partnership between cardiologist and pediatrician is very important. They looked at the relative rates of deaths, the relative rates of deaths, and looked at the non-congenital heart disease related. You can see infectious disease was very high, diseases of the respiratory system, diseases related to other chromosomal or congenital malformations. In other words, our children with heart disease don't just have heart disease. They have problems with their airways, they have problems with other congenital malformations that put them at risk for late deaths. Other thing that's important here is look at the rates of accidents, suicides, and alcohol-related deaths were also higher, a higher relative risk. And we know how many of our patients now, it's said that about 30 to 35% of our patients with congenital heart disease as they enter adulthood have anxiety or depression or significant learning issues. And then lastly, neoplasms. What we do on a child under a year of age when they are at greatest risk for the impact of ionizing radiation, our strategies of how we image children is very important. Multiple catheterizations put the children at risk. We need to be cognizant of the ionizing radiation exposure. Regular use of CT versus MRI is also another risk, and even the routine X-rays that children get in the hospital puts them at risk for late neoplasm. In summary, there have been tremendous advances in congenital heart disease. Early survival is better in the current era than it was in the early era. And late survival is better in the current era than it was in the early era. The survival is better if you have simple heart disease than complex heart disease. That seems rather intuitive. But there still is a gap, which means we still have work to be done here. And so what is next? I think we need new strategies for complex patients. You know, what are we doing as the initial correction? How do we do surveillance on residual heart disease? Could we develop better medications for heart failure? And what are the interventions for the non-CHD related morbidity? What are we doing with immunizations for infections, respiratory diseases, avoidance of cancer, and dealing with the psychosocial conditions? I also mentioned, and I'll go through this quickly, is this issue of the global burden of disease and disparity. Things are not equal around the world. And this organization, Children's Heart Link, is a wonderful organization. I've been involved with them and providing feedback to them on some ideas. And they published a 4-part series called The Invisible Child, in which they talk about the lack of equity around the globe. This is just a picture of the world and the proportion of patients without access to safe, affordable surgery and anesthesia. And you can see that it is an unequal map. There are parts of the world that have almost no access to safe, affordable surgery and anesthesia. They talk about the children born with heart disease. There is a constant number of children being born with congenital heart disease. And they talk about the under 5 mortality rate for all causes. And there have been significant improvements in the under 5 mortality rate from all causes across the world. But the problem is if we still have children being born at the same rate with congenital heart disease, and if we don't increase our ability to take care of children in some of those regions that don't have safe care, the amount of children dying from congenital heart disease are going to increase. And so we partnered with a group in Seattle which has a database that looks at all fatal and non-fatal diseases, and they track, I think, almost 160 diseases. And we have been, this will be published in Lancet in this fall, but we looked at the incidence of congenital heart disease, and you can see that there is a little bit of a different kind of incidence, and this has to do with survival and counting. Here's the important thing. And again, these lines are looking at the death rate per 100,000 lives. And we're looking over time, so the 1990s up to 2017. And what you see is this is the low SDI, or low socioeconomic index countries. And you can see there's a relatively high rate of death, and there have been no improvements in the death rate in the low SDI group. If we look at the high SDI groups, we can see that the rate of death is lower, and there is still improvement being made each year in death rate in high SDI countries. In the middle SDI and group, and the globally, you can see that there has been some modest decrease, but it really is the low SDI countries that we have not seen any improvement. And as a result, around the world, the congenital heart disease deaths the rate of the percentage of deaths due to congenital heart disease in children under the age of 1 is rising in just about every SDI group except for the high SDIs. That's what we call inequity. It's just not fair. And it's why the work that you're doing here is so important. And here's in low SDI countries, back in 1990, congenital heart disease was the 13th most common cause of death. It has risen in 2017 to the 8th most common cause of death. And that's just because the infrastructure has not been put into place to help the low SDI countries. So I'd like to leave you with this.